Okay, great. I see people coming in. I know that we have kind of a small group to start with. I imagine people will be joining as we get going, but I do want to respect everybody's time and go ahead and get started since we are at 2:00. Welcome back, everybody. It's great to see those of you who are here today, and I hope you're surviving in this kind of dreary day that we have. It's been a rough one in that sense, but we had a wonderful session last week. It was great to see those of you who were able to participate last week. I know it was a semester break day, so I hope that those of you who were able to attend were able to share with your teammates. If you didn't get to attend, we do have the recording up in the OneDrive. So welcome everybody, and we'll get started with today. So today we have with us Tina Batra Hershey, who is a JD MPH, and she's an associate professor in the Department of Health Policy and Management at Pitt Public Health. She's an affiliated professor at the University of Pittsburgh School of Law as well. And Professor Hershey teaches courses on healthcare fraud, abuse and compliance, healthcare law and ethics, and health policy and management and public health. Professor Hershey is also the co-director of the Multidisciplinary Master of Public Health program here at Pitt. And she's also an adjunct instructor of health law at Carnegie Mellon University's Hines College. Professor Hershey's recent projects include Tribal Legal Preparedness Project, which focuses on enhancing tribal legal preparedness during public health emergencies. And Professor Hershey also works using legal epidemiology to examine the impact of laws and policies related to infectious disease outbreaks and natural disasters. She's co-authored public health emergency law manuals and bench books for the District of Columbia and for Louisiana. And here at Pitt Public Health, she is much beloved and respected by both students and her colleagues alike. So please welcome me and please join me in welcoming Professor Hershey today. Take it away.
Thanks. Thank you, Cindy. I appreciate the introduction. And I'm excited to speak with you all this afternoon. I guess first, can you all hear me? In the Zoom world? Great. I'm going to go ahead and share my screen. And go. I have some slides for you. Let me just arrange you on my desktop. There we go. Okay, so yes, I'm here to talk to you about an overview of health policy and also going into health equity as you incorporate those concepts into your proposal for this case competition. I welcome your questions at the end, but if there's something you don't understand, go ahead and stop me along the way as well. So let's talk about what health means. So the WHO has the definition of health as the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. We have to think about the definition of health because it frames our consideration of what we want our health policy to be. We know that health is important to all nations, but the relative importance that each nation places on its the health of its population is, at least in part, proportional to the resources that they devote to the pursuit of health. So we know that some countries put a lot of money towards the health of their population, whereas others are more individualistic and don't believe that it's the government's responsibility or the nation's responsibility to put money and resources towards healthcare. We also know that there are health determinants or factors that affect health. These are also sometimes referred to as social determinants, but I'm using health determinants because it looks at personal, social, economic, and environmental factors that influence health. And you see that here health is in the center, and we see our physical environment, our behavior, our biological factors, socioeconomic conditions, and then our access to care, which is really what a lot of what your case competition case is about. Is that surrounds health and encompasses what we think about health determinants. Obviously, I'm biased as a lawyer, but I do think that law and policy are critical to health and well-being. And they've been instrumental and fundamental to shaping our behaviors as individuals, but then also when we talk about industries and how healthcare is practiced and how we have access to healthcare, and then also with the environments in which we live and work. I'll show you an example of how law and policy have been vital in achieving landmark public health goals in the United States. Now, obviously, this is U.S. goals and achievements, not globally. But when we look at 1900 through 1999, we see that vaccination as the number one achievement, and then things like safer workplaces, the decline in deaths from stroke and coronary heart disease, family planning, fluoridation of water, and recognition of tobacco use as a health hazard. Then we look in the first 10 years of the 21st century, again, vaccine preventable diseases are number one. But then we think about maternal and infant health, again, cardiovascular disease, lead poisoning. I find the last one slightly ironic when we think about improved preparedness and response to global health threats, not necessarily seeing that. So obviously right now, and Cindy mentioned the preparedness work that I've done, I've been in the infectious disease world since 2010, thinking about law and isolation and quarantine and things like that, and never thought that we'd get to this level of a pandemic and pandemic response that we see now. So those are those high level achievements that law and policy get us to, but then they're also used in everyday activities. So when you go to a restaurant, there's a food inspector that comes in and takes a look and either fines or shuts down a food establishment if they find issues with let's say rodents or some sort of infestation. We know that we have occupational safety standards. Our healthcare professionals are licensed. We look at law and policy in terms of our healthcare financing and delivery, patient privacy, public health disease surveillance. All of these things are happening behind the scenes every day. And a lot of this happens at the state level as opposed to the federal level. And so when you think about your country as you respond to this case proposal, you need to think about how the country is structured and how its governance happens in terms of whether it's at more of a national level or if there are these regional, state, local, whatever governments that are achieving or are reaching health policy and health law. So I've used the word health policy a few times. What is health policy? So first we have to define what public policy is. And those are authoritative decisions made in the legislative, executive, or judicial branches of government that are intended to direct or influence the actions, behaviors, or decisions of others. So that's a large definition of public policy. But then when we think about health policy, those are those public policies that pertain or influence the pursuit of health. And again, we need to look at our various levels of government, your federal, national level of government, your state, local, et cetera. So when we think about the goals of health policy, a major goal is improving health. But then we also think about equitable distribution of our healthcare goods and services, and also an equitable distribution of the financial burden. It does cost money to improve health and to provide healthcare services. And so we need to think about how we're financing things. And then achieve efficient allocations. And this is where we have budget constraints. And so, we might have these very lofty goals, but we have a limited budget. And so we have to think about and prioritize things because we might not be able to achieve everything and every goal that we want. So we have to think about political feasibility. Politics plays a huge role, and I'll be talking about that a little bit later, but we have to think about politics and political feasibility. And so sometimes we settle for less than what we want because we want to get to a solution of some kind. And we're witnessing this right now with the infrastructure bill that's currently being debated in our US Congress. There's a lot of negotiating going on, behind the scenes, but also very publicly. And so compromises are made. And when we think about health policy, health law, or public policy and law generally, a compromise is a word that's often used because we don't always get what we want, but we want to get somewhere along the way. So there are different ways that and different forms of laws and policies. I'll just run through a few examples of these. So the first way is through a statute. And that is where the legislative branch passes a law, then that provides the general framework. So an example of that would be the Affordable Care Act. So that's a sweeping law that reformed our healthcare system and the way healthcare is delivered in the United States, and it was passed by Congress. The rules and regulations are promulgated, it's the word that's used, by agencies. And this is when the agencies fill in the details. So an example of this would be the Centers for Disease Control and Prevention. They have regulations and rules related to how the federal government can isolate and quarantine an individual. There's very specific standards, when that can happen. Of course, there are also rules and regulations related to the ACA. Executive orders are issued by the president or through some other type of chief executive, like a mayor or a governor. So an example there would be former President Trump's travel ban. Another category or a form of law or policy would be what's called an operational decision. These are management decisions from agencies. So it's not a rule or regulation that's coming from the agency, but it's really how things are implemented and how more of the day-to-day operations. So when you think about the Medicaid program, Medicaid is a state and federal partnership, and you need to show eligibility, and each state gets to determine who is eligible for the Medicaid program in their state. And so the agency within the state sets forth a procedure for how eligibility for Medicaid is proven. And so that's not necessarily a rule or regulation, it can be this operational decision. And then our last category is case law or judicial decisions. So it's decisions by courts. And so this case that I have as an example is the National Federation of Independent Business versus Sebelius. And this is the case that upheld the constitutionality of the Affordable Care Act in 2012 in terms of the individual mandate, but gave the states the right to choose whether or not to expand their Medicaid programs. So huge decision that was made by the judicial branch of government. So we need to think about all these different forms of laws and policies and think about how we use those to craft a solution to a particular problem we identify. There are lots of actors who are involved when we think about formulating health policy or public policy in general. So we have our different levels of government, our healthcare institutions, as well as our professionals, the payers, who, let's say insurance companies or the government as payer. In the US, at least, employers are involved, consumers as well. Then we have interest groups and trade associations who are quite involved with forming health policy as well as other types of policy, sometimes more behind the scenes, other times very openly. So that's something to definitely keep in mind, is thinking about these, we call them interest groups or advocacy groups, or lobbying groups. There's a couple different names for them. Nonprofit organizations are very involved here, as well as religious organizations. So all of these actors come together, and they sometimes work together, sometimes they work at, they're at odds with each other, but they all have an opinion and what they think is the best solution to a particular problem. So I've used the word solution, I've used the word problem, and those are specific concepts that are involved in the health policy making process. So let me give you an overview of how this happens. So I teach health policy, one of the required courses for the MPH, and this is from the textbook that I use. This is a diagram of the policy making process. So we have a formulation phase, an implementation phase, and then a modification phase. And I'm going to talk to you about each of these steps. But we also have to think about our external environment that influences is kind of surrounding this whole process. So let's talk about this first step, policy formulation. The first thing that needs to happen is agenda setting. So before a policy can be made, there has to be something that triggers events to make to set off the process. And this is the process by which particular problems emerge, and then you get to the next step. So this is where we think about our problems, our possible solutions, and then we have to think about our political circumstances. And all together, they form a policy window of opportunity. If I go back here, you see there's the window that you look through that takes you from agenda setting to the development of legislation. So we know that there's a huge range of problems because health is affected by many determinants. I already showed you that graph of determinants. So we think about our physical environment, where we live and work. We think about our behavior as well as our biological factors. Research has demonstrated time and time again that social factors have an influence on health. And then how you receive healthcare in terms of the type, quality, and timing, that also has a major impact. So the problems that actually lead to the development of policy are those that are identified by the policymakers, that these problems are urgent and they're important. So we know we've got this huge range of problems. We're going to start sort of separating what we think are the most urgent and most important problems, and those are the problems that are acted upon. I mentioned political circumstances or political will earlier. So if you have a problem, and you have a solution, it doesn't automatically lead to a policy. You need to, I often call this part like having a champion or having political will. This is where we talk about our political circumstances, which can sometimes be the most significant factor when it comes to the policymaking process. And so these circumstances can include our interest groups and trade associations and all that lobbying that happens, whether the chief executive cares about this issue, and that's, again, the president, the mayor, or a governor, if they're acting as a champion, or if someone in the legislature, whether that's at the federal or state level or at the local level, if they're paying attention. So when you have that political will, that can take you, to the next step and get you to the next step. Without the political will, it's often difficult. And that's why we see, lots of proposed bills and things like that in Congress that don't go too far because they don't have maybe a champion or a champion that has enough power. So then we think about the implementation phase, and this is where it's the actual creation and running of the programs. And when I talked about that the operational decisions, this is typically performed by government agencies that make the decisions, the everyday day-to-day management, because this is primarily a management undertaking, and we're going to use our resources to pursue the objectives that are within the law. And so when we think about rules and regulations as well as operational decisions, they have to operate within the framework that's set by the legislature in the statute. So they can't go beyond what the statute provides, what power they're given under the statute. So a rule or regulation needs to follow the framework that Congress has set forth. And then the management decisions and the operational decisions need to follow that as well. So there's a lot for the agencies to do. And when we think about policy, our agencies, our executive branch agencies, are very, very important to how policy is formulated, but then also how policy is implemented. So there's 4 steps when we think about policy implementation: designing, rulemaking, operating, and evaluating. I'm not going to get into too much detail here, but when you think about, as you craft your solutions, and if you have a policy solution involved in your proposal, you need to go through all of these steps. And I think evaluating is a step that often doesn't occur, where you go back and you look to see how you've done. How is this policy working? And so I think my understanding is you have a 5-year time period. And so if you build in some evaluation in your process, where you can go back and look and maybe make some changes, which goes to, one more slide, goes to the next step. I think that would be a critical step for you, and it would be a valuable step for you. When we think about the success of the implementation phase, we really think about 2 variables: how the policy was designed or constructed, and then the certain characteristics of the implementing organization. So when you think about the design, and that's that first step in the implementation process, is there a sound hypothesis? Is there research that supports the policy and in its structure or its design? All of those things need to be on a sound basis. But then how much flexibility is there when you're doing the operations? Is it such a rigid structure that there isn't space for manipulating and changing and modifying, which is our next step, our policy solution? Or is there room to be flexible and room to address maybe some unexpected outcome or something like that? And then when we think about the characteristics of the implementing organization, we think about our managers, and this is sort of the people part. People implement policy, and if those people are not efficient, good at their jobs, in the right place, then we sometimes have a difficulty with actually implementing our policy. And if the manager is not the right fit with the organization, let's say the person is, an expert in tax law, but they're running an agency or operating a program that has nothing to do with tax, they might not be the best person for that job. So we want our managers to be capable and competent. And when we have administration changes, from let's say one president to the next, it's a real concern because people leave, then there's political appointments. And so maybe the best person isn't leading an agency or leading a division of an agency. So we are concerned with that as administration changes, and when we have interim directors and things like that, that maybe there isn't power and political will that's necessary to achieve our policy goals. As I mentioned, this last phase is policy modification, which is really different from initiation when we're starting off our policy process. So modification exists or occurs when we get the we look at that evaluation step and we see the consequences of existing policies. And so it feeds back into the policy formulation and implementation stages. And this is where we have change in our legislation, in our rules, or in our operational decisions. So when we think about contemporary health policy, most of those spring from existing policies because there's this feeling that we don't need to reinvent the wheel. So for example, the Affordable Care Act came from a model that was, that started in Massachusetts. So the ACA was built upon that. And so, I would suggest when you are looking at or drafting your proposals, think about what's happened already and go back and see examples maybe from other countries or within your country itself to see what's worked, and so build upon that as opposed to really starting from scratch. So when we think about how policy modification actually occurs, all three branches of government, the legislative, the executive, and the judicial branches, they're all involved with modification. So the legislative branch could be involved and stimulate modification during the formulation or implementation phases. Our executive branch monitors implementation and then can modify how a policy is implemented through promulgating a new rule or making some amendments to a rule. And then of course our courts can determine when modifications are needed, and we see that happen all the time. And we, throughout the policymaking process, modifications can occur. It doesn't have to wait. It's sort of this cyclical process. Stop there for a second and see if there's any questions before I move on to talk about health equity. Hearing none, let's talk about equity. So the definition, this is from Healthy People 2030. The attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. So the last phrase I used was health disparities. So health disparities is defined also in Healthy People 2030 as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. So we see that health disparities are driven by social and economic inequities. So this is a graphic from the Kaiser Family Foundation, which I think is a fabulous resource, and I use it quite a bit in the courses that I teach. But you can see that we have these different categories: economic stability, neighborhood and physical environment, education, food, community safety and social context, and healthcare systems, and how the different ways these categories or buckets influence a huge range of everyday aspects of life: literacy, food security, quality of care, justice policy and policing, and how all of these impact our health and well-being. And there's this across all of these categories, there's racism and discrimination. So we have to think about all of these things, and all of them have an impact on our health and well-being, which relates to mortality, morbidity, our life expectancy, our healthcare expenditures, our health status, and the functional limitations that individuals have. So when we think about paving the road to health equity, we see that, health equity is when everyone has the opportunity to be as healthy as possible. And we see these roads, programs, measurement, and of course, where I'm coming in is policy, laws, regulations, and rules to improve population health. But then underlying all of that is this infrastructure. So these are organizational structures and functions that support health equity. So you need that infrastructure to get to programs, measurement, and policy. So it's important to think about, as you're crafting your policy, think about the infrastructure that's needed and not just get to the measurement or not program or policy level, but build that foundation before you move on. So as I was getting ready for this presentation, I remembered this concept of health in all policies, or HIAP. It's not something that I'm super familiar with, so I'll do my best to answer questions you have, but I've included links and resources for you because I think it's really relevant as you think about your proposal for this case competition. So you might be wondering, what is health in all policies? So this is the definition from the WHO, and this is, and I have the link here. This is from the Health in All Policies framework for country action. So it's an approach to public policies across sectors that takes into account the health implications of all decisions, seeks synergies, and avoids harmful health impacts in order to improve population health and health equity. So this HIAP, it's not promoting a particular set of policies, but it's really an approach where you integrate health into governmental policymaking, and then you break down institutional barriers to collaboration. So we all know that, or hopefully we recognize that collaboration can lead to success, but there are lots of silos and barriers to collaboration. And so the idea behind the HIAP is to have this cross-sectoral collaboration. There are two common tools called a health impact assessment and then a health lens analysis. So when we think about HIAP, there's some principles that sort of ground this approach. The first is legitimacy, which is grounded in the rights and obligations conferred by national and international law. There's accountability of governments towards their people, transparency of policymaking and access to information, participation of the wider society in the development and implementation of governmental policies and programs. And this is when you can talk about stakeholders. Not everybody likes that word, but getting the population that's involved, or that's affected, involved in the development of the policy and as well as the implementation. We want to think about sustainability. We want to have policies that meet the needs of the present generation, but also don't compromise the needs of future generations. In particular, when you think about climate change, perhaps decisions that had been made, if decisions that were made by our previous generations had thought about the needs of future generations, maybe we wouldn't be in quite the predicament we're in right now. And then, of course, collaboration across sectors and levels of government in support of policies that promote health, equity, and sustainability. So this is, I have a screenshot of, this is a seminal work from 2013. I think this is a 358-page document. I have the link here for you. It's called Health in All Policies, Seizing Opportunities, Implementing Policies. So this was really an international effort, led, interestingly, by Finland and Australia. But Thailand is involved as well, and other countries. So this is quite global. As a concept, as an approach. And there's actually something called the Global Network for Health in All Policies that I also encourage you to look at as you craft your proposal. But when we think about our conducive conditions, we need resources and skills to analyze the impacts of major policies and proposals, thinking about that from the health perspective, and then communicate and negotiate across sectors. There needs to be a way to implement the decisions and then follow up on the impacts of the policy on determinants of health and distribution. We need information on what the health situation is currently, what are the causes of ill health, and when you look at your case, there's quite a bit of information there. We look at potential health threats. When we think about the health perspective, what would be an effective intervention or a policy? where the policy trends are and what proposals are. And so that's, again, information that needs to be incorporated. And then when we think about the policymaking process in the country where you're looking at, and thinking about the actors beyond the health sector. I had that slide showing you who's involved in healthcare policy, but we're thinking across and not just about health, we're thinking about across sectors. So who else is involved? And then we can see this political will, legal backing, and we need governance structures and processes for intersectoral communication and implementation. So again, we're trying to break out of our silos and have that collaboration across sectors and across governance structures. So there are a variety of frameworks here, but I pulled out the WHO's HIAP framework, which has 6 components. You may see slightly different components and frameworks across some of these documents, but according to the WHO, the first step would be to establish the need for health and all policies, and then what the priorities are. Frame whatever action you're planning. Identify your supportive structures and processes. And again, governance would be right there in that political will. Have some sort of way to facilitate assessment and engagement. And then ensure monitoring, evaluation, and reporting, and have that feedback loop. And then build capacity, and that's really through resources. So interestingly, this is a document, there are case studies for the region of the Americas related to health and all policies. And this is from PAHO, the Pan American Health Organization. So I encourage you to take a look at this resource because it's in the region where your case is from, and look at the case studies and see how, if you think there's some relevance to the proposal that you might be crafting. So there's, of course, some research that's related to health and all policies and whether or not it's successful. In particular, this article is looking at whether health and all policies and what this approach promotes health equity. And some of the themes that I pulled out from the article was that the political environment, how important that is, and what's called political opportunism. So striking when the moment is there for you, taking advantage of a moment in political time. Interestingly, these researchers talked about social networks, which are defined as a collective of professionals who know each other and work together on a common problem, and how that network, as opposed to institutions, often leads to successful health and all policies initiatives that promote health equity. And then, not surprisingly, when we think about equity and promoting equity through this health and all policies approach, we need resources, and that's money, but also people power. FTEs. We need people who are devoted to the approach. Whatever the policy, whatever that intersectoral collaboration is, we need people involved with that. And so this is a very recent article about health and all policies from 2021, talking about a key driver for health and well-being in a post-COVID-19 pandemic world. So I pulled out this piece of this article, and it says, this is an international article, so it said, whilst the concept of HIAP and the use of this health impact assessment and related processes are not new, there is an urgent need to use these much more strategically and explicitly, both nationally and locally. The health and equity implications of policies outside of the health sector, such as economic development and planning, have long been recognized. However, the COVID-19 pandemic and climate emergency further highlight the intertwined nature of impacts and policy responses. HIAP and the tools to apply it provide a way to understand the breadth of the impacts that are primarily affected and can deliver the SDGs, or the Sustainable Development Goals set by the WHO, and other related sustainability frameworks in an integrated way. The concept provides a vehicle through which to drive a sustainable, greener, more equitable, and healthier recovery from the current public health emergency and any future events, such unexpected events at the international, national, and subnational level. So this health and all policies concept is not new. It's that 358-page document that I have linked to talks about the history of HIAP. It goes back into the 19th century, but it really can be traced to 2006 presidential election in Finland, which I found really interesting. But obviously, as with anything, there's an evolution. And so just in the summer of 2021, the Association of State and Territorial Health Officials, ASTHO, and it was the Public Health Institute in Kansas, they did some surveys of individuals who were involved in HIAP, and whether or not, if you had to name this approach now, would you name it health in all policies, which I thought was really interesting. And so I pulled out this some of the results from the survey about alternative terms to health in all policies. So when you think about how else to frame HIAP, you can think about wealth in all policies, or a healthy environment, health across all policies, health lens, putting human well-being at the center of decision making. And then there were some equity related terms, equitable communities, equity in HIAP, health equity policy, racial justice framing. There are other terms to health, such as well-being, quality of life, livability, the social determinants of health, healthy living and healthy outcomes. Cross-sector terms, cross-sector partnership and cross-sector work. But then that last piece is very US specific, so I won't go into that. But it's interesting. So there's also, you see health in all policies, but you can also see health and equity in all policies. So there's this evolution where equity was part of health in all policies when you think about the definition, or as a goal. But now there's this more explicit reference to it, or there's the feeling that there's the need to have a more explicit reference to it when we think about the approach. So I'm going to stop there with this presentation. I have another one where I walk you through an actual solution to a policy problem. So I'll pull that up, and in the meantime, if you have questions, please feel free to ask them.
Thank you very much for that, Professor Hershey. That was really informative. I really enjoyed that, and I am going to leave the forum open for student questions at this point. You can put them in the chat, but also feel free to turn on your cameras and ask aloud.
All right, if there aren't any questions, I will go ahead and walk through this second presentation, which is just it's a US example, but it's an example of actually the policymaking process. So let me just get this up. Okay. Share my screen. There we go. So an example of a problem is sepsis. So again, this is framed in the United States. It's actually a global problem as well. So in the US, it affects at least 1.5 million adults each year and kills about 270,000 or more annually. 1 in 3 patients who die in a hospital has sepsis, and it's actually one of the leading causes of readmission in hospitals. And of course, at great expense. So it costs over $20 billion, and is one of the most expensive conditions to treat in US hospitals. So one of the biggest challenges with sepsis is diagnosis, because by the time it's recognized, it's often too late to prevent organ failure and death or serious impairment. So that means that early detection and then early treatment has a profound impact on survival rates, which led to the development of protocols, bundles, and algorithms for the early diagnosis and treatment of sepsis. So when we think about policy and possible policy solutions to sepsis deaths, of course, we can think about a statute, regulations, our operational decisions, and then quality initiatives sponsored by hospital associations. So those quality initiatives were occurring before we got some other action related to policy solutions to sepsis. But we have to think about those political circumstances to get us past the hurdle and get us to a policy solution. So particularly about sepsis, we had some interest groups and political will. So this is in New York State. So the little boy who's here on your screen is Roy Staunton. He was 12 years old and got cut in gym class and developed an infection. His parents took him to the hospital. He was misdiagnosed with, I believe, the flu. And then he actually died from sepsis at the age of 12 from a cut in gym class. So his parents started this foundation to what they call to prevent similar tragedies. And they actually, so this was called the Roy Staunton Foundation. They've since changed their name. Just in the last year, they've changed their name. But they really, one of their goals was to pass sepsis laws to prevent basically misdiagnosis. So they got the attention of the New York State Health Commissioner, who held a public hearing in response to the death of Roy Staunton. So they had interest group involvement, and they also had political will behind them. So what happened was, so that was in 2012. So in 2013, so very quickly, New York State became the first state to require hospitals to adopt and implement protocols for the timely recognition and treatment of sepsis. They also, this regulation also required staff education and then mandatory reporting to the state. And so, as I mentioned, this was really quick. So because of the political will and because of those interest group pressure and already those hospital associations that were involved, Roy died in April of 2012, and these regulations were effective in January of 2013. So really, really quick time frame. That's not necessarily typical of policy development. So I draw your attention to that because it is rather remarkable. Unfortunately, Roy has not been the only child to die of sepsis. This photograph is of a girl named Gabby, who also died of sepsis, and her parents went to their state congressperson and asked for help in terms of to prevent this tragedy. And so rather than go the regulatory route through rules and regulations, they chose to do it through the statutory route. And this is, again, where timing comes into play. So the law took 2 legislative sessions to be passed because it got stuck in committee. And so that means, so the law gets proposed, and then it goes to a committee, and then the committee has to take action before it goes to the full branch of, whether it's the House or the Senate of which legislative branch it goes to. Maybe there were other priorities, maybe other things were going on, but it took another session. So it took a few years for this statute to be passed, what's called Gabbys Law. So we have in one state, we have a regulation, in one state, we have a statute. We also had some operational decisions related to sepsis. So the CDC jumped into the fight and held public and health professional awareness campaigns called Get Ahead of Sepsis. And then we have, and so I have some screen grabs of some of the marketing material related to this campaign. And then CMS, the Center for Medicare and Medicaid Services, introduced a sepsis core measure called SEP1 as part of the fiscal year 2017 inpatient quality reporting program. So all of a sudden you have a lot of attention, and it's not really all of a sudden, it's over a several year span. We have different policy strategies related to solving the problem of sepsis. When we think about implementation, and going back to New York State, so the actual regulatory change in the New York regulations was very minor. And so what they being New York State Department of Health, issued they called a Dear Colleague letter. So they had a guidance document that accompanied the regulatory change. So that was more of an operational decision and the implementing portion of the policymaking process. So they have this guidance document. They also created this portal for sepsis data collection. And so if you go to the portal, I mean, it's got a data dictionary, it's got ways to submit reports, it's got a tremendous amount of information. And then there was an evolution of the tools and the processes related to how the hospital report to the state. So also as part of this implementation process, the New York State Department of Health issues an annual report related to the Sepsis Care Improvement Initiative. So they talk about the data collection, trends across the state, how hospitals are performing. So there is actual public reporting of how the hospitals are doing with respect to this, to sepsis in New York State. They adjust for, they publish risk-adjusted mortality, and then talk about the state's quality improvement efforts and the next steps to improve identification and care of patients who have sepsis to improve their outcomes. So there's been research related to this sepsis mandate, and I was involved with some of this work. So, we published a study about the association between state mandated protocolized sepsis care and mortality in hospital with, about adults. And then we also looked at pediatric outcomes. So in a nutshell, this was a successful policy. It did change the outcome of sepsis and patient outcomes related to sepsis in New York State. Featured in NPR about, it looks like this mandate related to sepsis works and has worked in New York State. One thing that this was not part of the study that we did, but there were, when we think about equity and we think about policy, following this initiative, this mandate in New York State, there were racial and ethnic disparities in the care that individuals received following this initiative. So, when you look at the conclusion, we found that while the implementation of the New York State Sepsis Initiative was associated with improved protocol adherence for all racial and ethnic groups, these improvements were accompanied by the emergence of a widening disparity in sepsis care between white and Black patients over time that primarily arose from lower performance gains in hospitals with a higher proportion of Black patients. And so this study suggested the need, an urgent need, to understand why improvements in sepsis care were lagging in minority serving institutions within the state, and how policymakers need to pay attention to these and anticipate these effects of quality improvement initiatives on disparities, and be cognizant and then monitor them to ensure that all racial and ethnic groups realize these benefits equitably. So not only do we think about a policy solution working in general, we need to think about the equity implications of this as well. And so I will stop my share and leave it open for questions.
Hi there. Thank you, first of all, so much for the presentation. It was really informative and interesting to hear both about the kind of process, but also seeing it in the form of an example was at least really helpful to me for understanding it. And I was interested in the fact that you mentioned kind of this public reporting of outcomes, that they're releasing reports. So I was wondering if you could maybe speak a little bit more to the value you think we could potentially find, maybe for our own cases, in some kind of model that requires this public reporting of outcomes. And is that mainly targeted at kind of the academic level audience, or is that designed more for kind of the broader public consumption? How does that look?
So in specifically speaking to the sepsis policy, it's interesting you talk about the reporting. So this was a hotly contested issue and was delayed because the hospitals did not want this data to be public. They wanted more time essentially to adjust to the initiative and to improve their quality, so that when the reporting did occur, they didn't look so bad. So that delay did happen, but I think it was a year delay. The reporting is designed not for academics. It is, or not only for academics. It is designed for the consumer, and uses a strategy that it's sort of like the shaming strategy. Like, if hospitals know that this is public information that anyone can find, they're going to want their hospital to be at the top, not the bottom, right? And so that is the power of public reporting. So I think it's a really useful tool that people and institutions want to protect their reputations, and so they don't want to be at that bottom level. Hopefully, I answered your question. Other questions? I guess I'll ask you all a question. Do you have an opinion, or what do you think of this health and all policies approach?
I don't know if I have an answer. I wasn't intending to answer this question, but I did want to ask just about health and all policies in general. Like, do you think you see this like being implemented here in the US? Like this like
yes.
idea?
Yes. So there's a lot of work that's being done, particularly in California and Massachusetts. So if you're interested in US examples, I can send you links to those. There's been quite a bit of work done in the health and all policies approach in the US. And that's why we're sort of now coming to this evaluation point of like, okay, what's working, what's not? Maybe it's time to change the name, think more about including equity more explicitly. But then I think the pandemic, the article, that the pandemic and climate change together, we're seeing the need to, or we're seeing a problem that crosses across sectors. And so this is not just a health problem. This is a problem across that hits every aspect of society. So we need to come together and think through a solution.
Okay, yeah, that definitely helps. Yeah, thank you. This presentation has been like really helpful since like I don't think I'm too familiar with like this area, but yeah, it's been interesting. Yeah, thank you so much.
Good, I'm glad. So I'll go back to my question, how the health and all policies approach. It's intriguing to think about. And other things I came across were like, how is the health and all policies approach different from just like collaborating, right? We all want to collaborate. And I think the answer really is being more explicit and obvious and methodical in the approach. So I mentioned health impact assessment and health lens analysis as two tools, and they're very similar. The real point that's different is when you start the process. That health lens analysis, the individuals who are involved come up with the policy themselves, whereas the health impact assessment is sort of going retrospective, where the people involved are policies already happened and they're going back and looking at it. So when you think about, you guys are at the point where you're crafting a solution. You're at that stage where it's your ideas, and so you can think through. When you think about that health lens analysis, that might be the point to start. And so the article that I have there, trying to remember which slide it was, it walks you through each step for the health impact analysis. Health impact assessment versus the health lens analysis. Can I just say I love the picture of the dog? Whoever's dog is their profile.
Okay, I guess I have another question. I don't know that it necessarily is formulated like a question as yet, but I think that one thing that our group has been running into, and in general, when I've been researching, there's kind of this temptation with a project like this to go straight in outside of government policy, because it feels sometimes like it can be easier to come up with a program that doesn't require you to jump through the hoops of passing something through legislation necessarily, or a similar sort of process. So I was wondering, could you maybe talk a little bit about your opinion on the value of, particularly for longevity of a program, the value of kind of a collaborative approach between the policy end and also the kind of outside of government realm project, if that makes any sense.
I just want to have a clarifying question. When you talk about outside the government, you mean like private institutions changing their behavior on their own?
Yeah, private institutions or like kind of non-governmental organization involvement in crafting interventions and solutions.
So I also have to say I am obviously biased, but I think that the law and policy has a place for sure. I do think that it's not the only place though, that you do, there's the formalized change through law and policy, right? Through a legislation, through a regulation. But then there's whether it's a ripple effect from that legal change, or oftentimes we see just even the idea that there might be a legal change changing private industry or outside of government. So whether you actually have that policy change, but just the almost a threat of let's say more regulation can lead to change. I think from a longevity perspective, though, having whatever the change, policy, proposal, whatever you have memorialized through law leads to a more sustainable change. Because let's say you're a private company and your CEO is passionate about climate change and wants to change the behavior of the company, but then they retire or they resign, they leave, and so you lose your champion. So if the law is changed, and there's no choice about what you're doing.
That helps. Thank you.
But your point about the hoops is well taken. That is, there are lots of hoops. There's no doubt. Like I said, with this infrastructure bill, we're witnessing the hoops right now quite a bit.
Hi, thanks again for your presentation, like Isabella said. I appreciate it. I had a question, a kind of specific question, like in terms of a retrospective perspective, when you're doing quality improvement initiatives, I guess after you've seen some of the work that's been done, is that typically something that's best to contract out? Like you're not reviewing yourself? And also, is that better to be like an annual thing or like continuously you're doing those check-ins?
Okay, those are two great questions. It's hard to answer because it depends on your situation. I think there are pros and cons to having an outside entity do the review versus internal. And I would argue, assuming that resources are available, that you would do both. Because sometimes you know yourself so well that being an institution, and then you can evaluate yourself. But then you also may be myopic. And so having that outside entity come in helps you see other perspectives. In terms of timing, again, we have to think about our resources. So it might not be possible to do an annual review for every policy. It might be better to do, and this is going to depend on the industry, the area. It might be better to do annual reviews of different things with the idea that maybe on a 3 to 5 year cycle, you get back to all the things, right? I mean, it's a very generic answer, but I feel like I have to be a little more generic because it's such a broad question.
Thank you.
I wanted to just also insert in thinking about outside the government or inside the government, keep in mind that your presentation is to the World Bank and the Guyanese Ministry of Health. So you're already talking to the government. So
very good point.
So that was we do have a tendency to forget about that. So the ministry will be involved in some way. I just throw that out there to not be thinking like either or government or not government, because it's clear that that the ministry would need to be involved in some way potentially.
And Cindy, is the ministry, who's holding the funds?
It's not specifically laid out, but it's somewhat implied that because the World Bank is involved, and it's $50 million infusion, that it is coming externally, right, from the bank. We didn't specifically spell it out. So the contract will be awarded to the team that that the World Bank and the Guyanese Ministry decide have developed the best strategy for the mission. So it is sort of implied that the money's coming is coming externally.
Okay. Other questions?
I want to just say, while people are thinking about additional questions, I love that you brought up the health and all policy, right? Because that really is, it really is something that pushes us to think beyond what we normally think of as health policy, right? The health effects of other policies, and particularly in this situation, because we are talking about we're in the context of climate change, and we're also in the context of increasing exploitation of natural resources, right? And so is there policy about that, or isn't there? And how does that potentially, is there health and all policy, has that health and all policy approach been adopted in some of those policies as well? So it's definitely are things to think about in terms of in terms of creating a sustainable approach to this. I think one of the things that that I just want to, that I think about, I think one of the things that is worth thinking about in this situation is sustained funding going forward when we're looking at a low resource area where there are outside companies exploiting resources, right? Is there a policy potential to mitigate some of that damage or some of the consequences, the health consequences from that natural resource exploitation, either in terms of curtailing the activity or providing some sort of compensation that could then fund resources going forward when there's like destruction of habitat or destruction of ecosystems that then have health consequences that would need to be addressed by this proposal, right? That would have emergency health consequences. So those are the sorts of things I think that this presentation just really invites us to think about, like how we can just really approach the problem comprehensively, and what role can this approach of health and all policy have in the solutions? So I'll just throw that out there.
Well, and Cindy, you brought up a point. So think about taxing. So that's through a law. And, I can't quite remember all the details in terms of the natural resource exploitation, but that's taxing policy is a way to change behavior and also generate revenue. So I think definitely keep that in mind.
Yeah, I think that's an excellent point. And I think we have a tendency here to forget that we have tiny little emergency resources taxes tucked into a lot of different things, right? And that is one way that that's a policy that was established a long time ago, to the point that it's nearly invisible now. We're not as aware of it, but that it does create a sustainable source of revenue for things like emergency services, things like ambulances, and well, just any type of emergency service. Yeah. I think it's hard if you're not a policy person. Sometimes I think people have a hard time remembering like what all, like so many things are policy that you might not think of as policy. So that's what I was just sort of, so I love that you brought up taxation, right? We might not think about that.
Well, taxation, zoning laws. People don't realize how the impact zoning laws have on health and the behavior. Yeah.
Right? A policy, exactly. That's a really, yeah. Mm-hmm. Zoning laws, and then coverage of services, like what the service area is for a certain type of service, that can be a policy as well. Like there is a lot that we don't, we tend to take for granted just because we have that infrastructure in place. Not always, but in many places, for better or for worse. And so we don't necessarily get into that nitty gritty of things like that. Yeah, zoning is another excellent example. So land usage, zoning, taxation.
So when I read things like this, I'm like, all I think about is law and policy. So it's just, what your training is really influences how how you think and how you problem solve.
Oh, that's so true. That is so true. Well, let me just ask you, how many? We have 15 of our team members here, so we'll give them a few hints. What sorts of policy things come to mind for you? I mean, you don't need to lay out an entire strategy, but give us some hints as a policy expert. What sorts of things come to your mind when you do read something like this?
So tax was the first thing that came to my mind. Like, okay, so whenever you get that big pot of money, and I think about this across, globally, not, whatever, locally, that's great, but that you're going to go through that and then what? So I really think you need to get to that then what? Once I've burned my $50 million, where do I stand? And so having that revenue generation to sustain your policy, I think that's the first thing I thought of. What struck me the most, I think, when I was reading the case was the need for the roads. Because you can put all the money into buying all your ambulances and do all your air, whatever. Think about your roads, but then also think about the helicopters, the other non-road, other alternatives. I don't know very much about that, and so I can't say too much. But I would think outside the box a little bit, because when you look at those pictures, like the mud, it's just going to get worse. And so taking to the air might be a better solution than investing in too many roads and too many, motor vehicle ambulances. Trying to think of what else. I know I had other things. I'm just blanking for a second. Give me some more details about the case. The roads.
So we're looking to expand emergency services to the hinterlands, which
The
is
hinterlands,
a more is a more remote, difficult to reach area.
And maternal child health, the snake bites.
Yes.
So
Exactly.
so then we have to think about our healthcare professionals, right? Training the workers themselves. And so this is some work I've come across. So I work with tribal nations, and there's this real push to train people who are Native American, who are on the reservation, train those people, and pay for their education. It's not bringing outsiders in, it's training, the insiders. And so they already understand the culture, and they understand the cultural values. And so that you won't have that mismatch. And so by investing with your own people, it's like a win-win. So you get more the professionals that you need, but then you also, because you have this under-resourced country, you're helping the economic development of the individual as well.
Yeah, that's an excellent point. We had last week, we had a head of emergency services talking a great deal about how you train personnel. And he talked a lot about standards for personnel and like who can do what, like what the different tiers of training are. And some of those are particular to the US, but some of them are global standards as well. And that also seems like there'd be some policy implications there in terms of, certainly informed by current medical standards of what people need to be trained in and what they need to be capable of, but there might be some policy implications for who has to be on site and how can things be handled and what sorts of responsibilities do we allow trained individuals to have in these really remote areas that might be slightly different than what would be policy approved in other areas. So that's, I think, another policy area that can be, again, we've got the Ministry of Health, so that would be something that they would have the authority to make some decisions about as well. And I think that can really, like you said, you get a lot more out of what you have to your resource sources, because you have people who are already very culturally competent, and they're also located on site, right? You're not trying to convince people to go move to an area. So that's a huge savings. But then you also have the potential to define a scope of work that's much more culturally appropriate, or much more appropriate to the context, I guess, too. And
that's called scope of practice. So scope of practice is, the services that you're basically legally authorized to perform. And so in the United States, we have a scope of practice for physician assistants, nurse practitioners, physicians. And so when we think of the different terms, allied health professionals, physician extenders, advanced practice professionals, a lot of times they need to be supervised by a physician. And sometimes it's, one physician can supervise only 5 PAs or something like that. But when we have a crisis, like a pandemic or a hurricane, we broaden. So we say, okay, that one physician can now supervise 10 PAs. So you can think about solutions like that, where in these, this remote region, we'll push the limits a little bit in terms of how much supervision or what types of services the EMT can provide.
Mm-hmm. Yeah, exactly. I think the other thing we've really seen so much of, I work at a family medicine residency as well, and we see the use of virtual provision of care, and the extension of how that can be provided and how people can be supervised virtually in providing care. So I think there's potential there.
So we have to be careful with telehealth services. And again, going back to my tribal work, there isn't broadband access. And so we don't have those digital solutions because of the lack of broadband access.
That's a really good point. Yeah, I'd forgotten completely about that. It would mostly be, I think we're assuming there's going to be radio, there's some radio coverage. So it would all just be, audio. There'd be no video. Yeah.
Yeah. So it's it's a great solution, but you have to have that infrastructure. Yeah. So when you think about your proposals, and that graphic of the road to equity, infrastructure is the foundation there. And so without that, we could have the most creative policy solution, but it would be ineffective essentially, especially over the long term, because we lack that infrastructure.
Yeah, exactly. And even if if there's even if there is some infrastructure, but it's not reliable enough to, to really make sure services are available. Yeah, excellent.
Wondering if anyone has any other questions or any ways I can help.
Well, I have another one. I know, but if anybody else has one, feel free. I always have a million questions. So, but I'm thinking back, I'm thinking again to that local, that training of local people, and sort of, is there any need for sort of employment policy for people who might not be, again, I'm wondering, I need to go back and look at the case in terms of like citizenship and people in different areas, and maybe employment by the ministry. I guess they would still end up all being Guyanese citizens, so maybe not. But there might be some policy implications there as well, right?
Well, you may have to think about immigration law. If you're talking about bringing people in from outside, what types of immigration laws are in the country? Do they have to have, in the US, it's like a green card or a visa, those type of questions.
Yeah, that's a good point. Okay.
I'm trying to remember about the snake bites. There was no treatment. Is that correct? For the snake bites? Or the treatment that wasn't really available, it wasn't commonly available. There was something about the snake bites that it's almost there.
Yeah, it's a common emergency that they have, and it's not available locally. I think that was the whole thing, is they don't have treatment available locally. And so how to either get treatment to people or get people to treatment. And that's the same thing with maternal emergencies as well, right? How do you get somebody to them or get them to some sort of site? And the snake bites, but it just was a really common emergency that they face because of
and so it might be investing in whatever the anti-venom or whatever the treatment is, having that be part of the kit, that each EMT has or something like that. Yeah,
that was one of the things I thought that Dr. Hagamed talked about last week when he was breaking down sort of what is involved in emergency medical services. He did an excellent job talking also about how the low tech approach to a number of things, having ice on hand if people are suffering from hyperthermia or overheating and having cold water for dehydration, things like that, and having reliable sources of that for people at work sites or at really remote sites, and having them be part of what the emergency personnel would have with them when they came to treat people. I thought that was a really fascinating idea. We tend to think of the expensive, high tech, the big ticket items, but and so that anti-venom would certainly be something that policy on having that always on hand, having that available. When I was in the Peace Corps, one of their policies was that we always had to have oral rehydration formula in our possession, because that was like the biggest reason people got sick was dehydration. So we always had to have some. So as soon as you were out, you had to make sure you went and got more.
And that's policy in the sense of not a law. That's just sort of the operational policy. So it's a great example of maybe it's not jumping through as many hoops to get a statute passed, but it's this sort of institutional policy.
That's a really good point. So that would be more like Ministry of Health policies for their workers or for their,
And so a legal term for that is like the standard of care. And that it's relevant in the sense that, well, it's irrelevant. The standard of care can lead to negligence action. So if you don't meet the standard of care, so I don't mean it necessarily in that way, but it's sort of the accepted practice of the medical field. If they have to carry, or the EMT field, that they carry the anti-venom treatment.
Yeah.
And so $50 million seems like a lot of money, but it really isn't over a 5-year period. So thinking about some of that low tech, those low tech solutions might be a really good idea.
Yep, exactly. Well, and I really like the idea of the community health worker. I mean, I think that's one of the things we see. We're finally moving to that model here in the US in a lot of communities, just because it really does have the opportunity to put people on site who maybe they don't know everything, but they know enough, right? They know enough to treat the most common and the most urgent things that are happening. And they know how to stabilize people until additional help can arrive. And they know enough to recognize when, like, we have to go now, and that's so critical. I mean, that's one of those, again, really low tech solutions that can really give you a lot of bang for the buck in terms of community services, especially in remote areas where transportation is such an ongoing issue.
Well, there's also trust there, or potential for trust with that person who's part of your community, as opposed to like an outsider.
Yeah, that's an excellent point. I hadn't even thought about that. Yes.
So I spoke at the Tribal Public Health conference a few weeks ago, and one of my co-presenters was a community health worker for the Hopi tribe, and she is all about related to the pandemic and just all the work that they did, the trust, that whether it's vaccination or testing or the like, they had the trust of the community, and so the community knew that that these workers were looking out for their best interests, and that really went a long way.
Exactly. I think that's one of the sort of secret weapons in terms of deploying a health system or a health intervention that can really get on its feet and get moving pretty quickly, is to be able, but you have to invest the time in bringing those people aboard too. So, but from once implementation happens, because that community trust is there, if workers are brought in and trained appropriately, that can really be a way to get a program going and moving. Yeah. I think there's also an element of that for the evaluation, right? For evaluating either the policy or the intervention, is having that local evaluation of people who really are receiving the services or providing the services versus, I mean, they had asked about somebody coming from outside or having somebody within their own service. There's a lot of benefit there, because I think people can really evaluate the cultural appropriateness of the service and sort of the cultural reach of the service. Like, is it really reaching the people that we want it to reach? So, yeah.
Can I ask another question? I wanted to see if you had any suggestions for 2 different areas when I was looking back over the case that I think might be related to policy. One was, I know they mentioned that the government had made attempts to make pesticides less accessible since it's sometimes used for the suicide. And the other one was that the mining industry is like not regulated right now by the government. So I don't know if there was any policy related solutions that.
Yes. So in the US actually it's an agency called MSHA, the Mine Safety and Health Administration. And I know this because my husband, who I met in law school, worked for MSHA when we were law students. It was like an internship. So it's basically the equivalent of OSHA, the Occupational Safety and Health Administration. So they're just specifically for mines. So that's something that's literally the extent of my knowledge about MSHA. But we definitely have mine regulations here in the US, and other countries across the world do as well. So I think that would be, I'm going to use an easy policy solution that wouldn't cost the government money. So I'm not sure how you're able to spend your $50 million, but that's industry would have to change their behavior. And so it would be one of those, I don't think, just my understanding is that you wouldn't be spending any of your money. Maybe you have to hire some employees, set up the infrastructure for the agency. But in terms of the changes to the industry itself, it would happen by those private companies. And the other one is about pesticides and availability. That one's a little tougher, I think. I mean, if you think, again, I'm going to use the US, we have things that are sold behind the counter, whether it's, the cough medicine, things that are used for like making methamphetamine that we can't access easily, and of course, tobacco products and things like that. So we could think about having pesticides being kept in a different location, not being easily accessible. So still sold, still available, but just not as easy to get.
Mm-hmm.
Again, a low cost option.
Mm-hmm.
So I would really encourage you to think about those easy, low cost options so that you can stretch your budget.
Yeah, those are both great questions to ask about those. And yes, it's great to hear like policy, right? Policy potential, maybe not solutions, but certainly ways to regulate and mitigate the potential damage from each of those. So yeah.
And I think that's a really good example of this health and all policies approach, that we're looking at pesticide availability, we're looking at the mines, but then we're also thinking about the emergency services and how do we equip our EMTs. So we're looking across sectors, and they're all going to have an impact on the health and well-being of this population.
Thank you.
Do we have any other questions? We're coming to our 90-minute time, but I certainly do want to give you additional time if you have questions you'd like to ask. I'd also like to give Professor Hershey, if there's any last comments you'd like to make, having heard the questions that we have. Any other closing comments you'd like to make in the meantime?
I do encourage you to look at the case studies. So I'm going to share my slides and I'll send them to you. Take a look. I've made sure to put the links in. The PAHO examples, I think, there's nothing specifically on point, I think, for your situation, but they're examples of strategies that have worked in the region that you're in. And so I would definitely take a look at those to maybe stimulate your thinking. And offer possible, these policy solutions. But then take a look at the framework and all the links that I provided to you. I think, if you're going down the policy route, they would be helpful. But when you, again, that reference that 358-page document, they talk about the policy window of opportunity. They talk about the political will. So it ties it all together, I think, really nicely. And you don't have to read all 358 pages because that document itself has a lot of case study examples. So, Finland example is not necessarily going to be relevant to you. And in fact, over the summer, there was this global network for health and all policies. They had a conference, but was centered in Scandinavia for the most part. So I didn't really draw from that, but there's a webinar from the summer. So something else you can take a look at as well.
Nice.
So I've heard about health and all policies for years now, but I was really curious to see if it was still in favor. And the answer is yes, but potentially the idea of changing the name. And there is some discussion about, health and all policies. What does that mean? Because I don't think it's all that obvious what it means. And especially with that equity aspect, that maybe it needs to be more explicit.
Mm-hmm. Yeah, excellent point. Excellent point. I do think a lot of people don't know what it means. And I think that as public health professionals, we really focus on it. But again, all the rest of, there's just that whole other realm of policy that isn't focused on health. And I don't know that they are often reminded of the need to be, or the opportunity to think about health and all policy. So yeah, it is interesting to see where, and it will be interesting for this group to see where you could potentially go with some policy solutions to this case. Okay, Elaine, there were announcements I was to make at the beginning that I know I forgot. So let me circle back and.
Well, I just want to thank Dr. Hershey. It was very informative. So much for us to think about, so much for us to incorporate. I encourage the students, her presentation will probably be in our OneDrive by Wednesday or Thursday. maybe a little sooner than that, depending on.
I'll get it in there sooner. I'll get it to you sooner.
No, but we did record this presentation.
Oh, okay.
If that's okay, and then we'll.
Sure.
I'm not. So I encourage you to have your teammates watch her presentation, because I know the judges will be looking for many aspects that she's highlighted. I just wanted to know if this is logistical stuff, so if you want to go do the rest of your Friday and have to yourself, Dr. Shea, it's up to you. But for this,
I'll sign off. I have another meeting that's coming up. But,
okay. Thank you so much. Thank you.
Thank you.
Good luck.
Yes.
Thank you.
You're welcome.
Yeah,
Good luck to
great.
all the
Thank you.
students. And
Okay.
I enjoyed it. Thank you.
For the students that are on who are still remaining, please remain on for a couple more minutes. I know many, there's a couple of teams that had to be reconfigured because of some students dropping off. I just encourage you, the teams that, let's see, yesterday I sent 3 teams, 3 new members. I encourage you guys to start meeting if you're not already meeting, and bring in the new team members because they want to participate in this competition. So they said, yes, please reassign me to a new group. And if you guys have any questions about, any about these new team assignments, for the most part, it's only just been 3 teams. Now, I will be sending out an email late next week about when we're presenting our presentations. I believe we said at 2:00 on the 5th, Friday the 5th in 1500 Posvar Hall. There will be instructions in the email as to students when they present, they can stay and listen to the groups that will come after them, but you cannot come and listen to a group if you haven't already presented. And all materials need to be sent to me by, it's going to be in the email. I think it's 11 a.m.
Yeah, I think
Yeah.
it is 11 a.m.
11 a.m. So then we share the information to the judges. They have a few hours to look over it. So you want to be prompt in sending it to me by 11 a.m. on the day of the presentations. We will be, Cindy and I will be available, or Dr. Salter and I will be available on next week at 2:00. If you have any questions, we'll stay here for like a half an hour. If you have any questions about the presentations, I'll send that email out before that in case you have any questions about the day of. But we will be here at 2:00 next week.
Yeah, absolutely. We'll be here from 2 to 2:30. Certainly if we start talking at 2 and you have questions past then, we can say a little bit longer. And then, so you'll get all your instructions by email. And we will also have sort of I'm not exactly sure where, but we'll have a little bit of a holding room for groups as they're going in. Essentially, you can't hear the other presentations until you do yours. Once you've done yours, you're welcome to stay and sit in the room, in the auditorium, and listen to the rest of them. So we'll tell you where that will be. And we'd like you to be there. Well, we'll put it all in the email to be there well ahead of your presentation time. We'll have the schedule. We will record your presentation, so you'll have those to reflect on. And again, if you want to do this again, you'll have a way to look at your performance and improve. We'll have feedback from the judges. I think that's everything. Right?
I think so too. And keep in mind the folks that have presented, they said that they would be there, not there the event, the day, but I mean, available. They have shared their emails. So if you have, specific questions, you can reach out to them.
Yes, absolutely. I think everybody involved has really enjoyed talking to you about the project. They're really curious to see what you're coming up with for your strategy. So I'm sure they'd love to hear, I'm sure they'd welcome hearing from you if you have questions as you go along. Yeah, and are there any other questions for us right now, just in general, that maybe you didn't think of earlier that you'd like to ask before we go for today?
Thank you, Emily. Emily's also available.
Oh yeah, wonderful.
Yes.
Did you put her email, reminded you in the chat? Yeah, and also I know it's a low energy Friday. This was a rough week, I think, across campus, right? Everybody's in the middle of midterms and everything's coming due. So I do understand that it's a rough time, and I really appreciate your showing up. And I also know that you keep in mind, like, this is actually, maybe Emily can comment on this. I'd say don't panic if you still have a lot left to do before the competition, because this is the time when it's all starts coming together. It's challenging to work on a whole lot of it ahead of time. So don't panic. Right. If you still have a lot of it to do. And we do have next week off, but you're, like I said, are welcome to come to the Zoom. You're also welcome to meet during that time period with your team members if that's the time you have available. But definitely don't panic if you still have a lot to do. Isn't that right, Emily? I remember you saying last year you did a lot towards the very end, right?
Yeah, we kind of scrapped our case and did the whole thing in a week. So and that was definitely our fault too. I don't know that that's the norm, but yeah, don't freak out. I know everyone's priorities are on midterms now, so you'll get it done.
Exactly. You will. And we'll have a great time that day. We really will.
It's an interesting case. I'm really looking forward to hearing your proposals now that I've attended all the lectures.
Yeah, same. Well, I enjoyed them all last year. It was really, last year we had to do them all on Zoom. I'm really looking forward to being able to do them in person. I think that will make it just a little bit more fun, a little bit more, the logistics I think should be, knock wood, I hope will be a little bit easier than they were last year on Zoom. That was really challenging. So, Okay, great. Thanks everybody for being here, and have a great weekend.